So the issues to address in this talk are, does resection take care of the underlying cirrhosis? What are the resources and setup that is required for a transplant? And what is the difference between procedure-related morbidity and mortality in these two modalities of treatment? And of course, the big question, what gives a better survival? Is there any survival advantage in either of these modalities? So cirrhosis has a field effect on liver as well as the entire body, but especially when it comes to hepatocarcinogenesis, cirrhosis is the driver of molecular dedifferentiation, and that converts to malignant transformation and then metastasis. Apart from hepatocarcinogenesis, cirrhosis also leads to other complications like portal hypertension, ascites, and liver failure. And the limit of resection is that it does not address the cirrhosis and its resultant complications. It only takes care of the liver disease, the hepatocellular carcinoma. It does not address the liver function status. So after resection, if the recurrence occurs within 2 years, it is to be assumed that it's a true metastasis and it was the disease itself that had produced micrometastasis. However, beyond 2 years, in a cirrhotic liver, it is de novo carcinogenesis that has developed because the resection part failed to address the cirrhosis part. Now, when it comes to utilization of resources, transplantation is very resource intensive. You have long waitlisting of patients. Now, of course, with live donors coming in, we are using live donors much more than before. We are using marginal donors much more than before. But again, the load of which it puts on healthcare is much more than what a liver resection does. You have additional utilization of resources in a live donor. So these are the factors which will drive up the cost of transplant. And in a country like India, where that can be applied to patients who can very well undergo liver resection, that part is to be seen. Now, when it comes to surgical outcomes, liver transplant versus liver resection has significantly shorter operating time, significantly lesser blood loss and transfusion requirements. And of course, technically, it is much less demanding as compared to a liver transplant. In the early post-operative period, the morbidity of a liver resection is lesser, even though the liver transplant is done by a specialized team. The morbidity of liver transplant remains higher, and in addition, you have morbidity of the donor himself. Liver resection has less percentage of bile leaks, and that is another factor that drives up the morbidity in transplant. When it comes to late post-operative period, the mortality within first 6 months is very minimal when it comes to liver resection versus nearly 5.5 to 6% that comes with liver transplantation. With transplant, of course, you have all categories of rejection, including acute on chronic and chronic. And to avoid that, the immunosuppression that we give, that has its own set of complications, including systemic toxicities as well as systemic sepsis. So these are the problems with liver transplantation. But even if you do a liver transplantation, is there any difference in the survival rates? Now, this is the data from multiple studies, which shows that the 3-year survival, over 3-year overall survival in liver resection is in the range of around 75 to 90%. And the 3-year disease-free survival is to the tune of 50 to 70%. When it comes to liver transplantation, the 3-year survival and the 5-year survival is in the similar range as far as the Milan and UCSF criteria are concerned. These two are the strictest of criteria. And now with newer criteria coming in, like Kyoto criteria, which allows resection up to 10 lesions, with other criteria that allow much more liberal transplantation, the survival rates may not be this high either. So the summary of this is that the advantage of disease-free survival after liver transplantation is seen after 3 years. So the patient has to survive 3 years at least to see a significant advantage of liver transplant. Similarly, the overall survival advantage is seen after 10 years of survival. And the 5-year survival rates are not that significantly different when it comes to liver resection and liver transplant. Now, liver transplant does offer lower recurrences within Milan criteria, but that is when there is no microvascular invasion. As Gunjan spoke, with macrovascular invasion, the survival goes down. Even with microvascular invasion, the chances of recurrence are much higher. And you can always have a salvage transplant after you do a liver resection. So in a transplanted liver, you have to manage a recurrence. After resection, you can always go in for a salvage transplant. So this is the current BCLC staging, where estimated survival beyond 5 years is there in both resection as well as transplant. So the take home is that the low MELD score patients, they have better chances with resection rather than with liver transplantation, because MELD score adds extra points for HCC. So it is a modified MELD that is taken in consideration for transplantation. And in addition, child A is a relatively preserved liver. So you have a low rate of progression of cirrhosis, you have a low rate of decompensation, and the 1 year liver-related mortality is only 3%. So these are not patients who are in immediate need of a liver. So why to give them a new liver? That is the point. And that is highlighted by most of the guidelines in the recent times, where single as well as 2 to 3 tumors in a well-maintained child A patient, most of the guidelines recommend liver resection over liver transplantation. So to summarize, liver resection is technically easier. It has lesser cost and resource utilization. It has lesser morbidity, despite there being some risk of post-hepatectomy liver failure in trisectionectomies. It has less mortality, and it has comparable survivals with an open-ended option of having a salvage transplant. With liver transplantation, you have low recurrences, but then the recurrences will be more difficult to manage. And so liver transplantation may not be justified in child-pugh A patients. And I conclude that liver resection is still a better option for HCC as far as child-pugh A is concerned.
I am Dr. Rajvilas, and I am a consultant GI, HPB, and transplant surgeon at Alexis Hospital, Nagpur. So, Prasad has already given us a brief introduction about the topic, and Gunjan has made my work slightly easier by giving us how the tumors develop in this cirrhotic liver. So, liver transplantation, hepatocellular carcinoma, and liver cirrhosis. I'll say they're more of like a tripods. So they have some of the other crosslinks with each other. When we see chronic liver disease as a cirrhosis, we know there is a progressive liver disease damage is going on, and there is a continuous ongoing there is an ongoing continuous damage going on in the background, and that's why these patients keep on having some of the other insult keep on in the as the time passes. So we know the pathology that the cirrhosis develops by forming regenerative nodules, and there's a persistent fibrosis going on, and with this continuous insult there is some amount of field effect in the liver, and that's why there is some amount of dysplasia, then malignancy formation, and then they crop up one by one. So many times in the initial period, as Phadke sir has told, and even Dr. Suri has addressed, that regenerating nodules and the small HCC is very difficult to diagnose, which is HCC and which is regenerating nodule. So sometimes that can be a diagnosis difficulty to say whether there is solitary HCC or there are multifocal. So if we find there is a single HCC or single nodule in the liver, how sure we are in these patients who have, although their liver function is preserved, but the other nodules are solitary multifocal HCC or regenerating nodule. So this becomes very difficult for us to know how much is the exact percentage. So there was a study by Edusurg in 2008. So they mentioned that almost 29% may show multiple HCC on intraoperative evaluation or on the final histopath when these patients are being operated for a solitary single HCC. So this makes us to think, do we need to know this? Because the outcomes for a multifocal HCC and a solitary HCC way differ. So if this gives us a clear idea of what type of HCC they are, we can be more solid on our prognostication and the further treatment plan for these patients. So we already know the treatment plans, like if you want to give a curative option to your patients, there is nothing else apart from resection, liver transplantation, or percutaneous ablation. And other non-curative but palliative procedures are those procedures which can be used for downstaging the disease are like transarterial chemoembolization or a transarterial radioembolization, or maybe a chemotherapy in the form of sorafenib and the newer agents, or very few studies which have shown that there is some role of SBRT as well. So when the patient are having liver cirrhosis, sorry, there are no liver cirrhosis, this is SCC. There is no doubt that the first line of treatment is a parenchyma preserving liver resection when the tumor is resectable. But when the patient develops liver cirrhosis and the liver function is not good enough, or the liver cirrhosis in the tune of child B or child C, then we get all these criteria like Milan criteria, Edusurg criteria. So if the tumor is fitting in this criteria and there is child B cirrhosis or C cirrhosis, then in these patients we can think of transplantation as a first choice of option, because that will give us a long-lasting cure. So if they are not fulfilling the criteria, then there are some things like TACE and ablation. We can do that and bring down them to the criteria, and then we can transplant. And if the child B cirrhosis patients, they are beyond all these things and transplantation is not feasible, then yes, palliation is the only way. But there is a big gap between the literature availability on the treatment of HCC when there is a fairly preserved liver function. Right. So that's why we are debating. So this is a medical field where there is nothing gray or white. There is no black or white. It's always in the shade of gray. So here I would like to present some data. So at least it will give us some insight into what is the matter and how can we individualize, or which things can be individualized to which patients. So when these patients are there, we have to consider either resection or transplantation for this for the treatment, because ablation per se may not be feasible for larger tumors or multifocal tumors. So the criteria which are important to discuss here are whether they are fulfilling Milan or Edusurg criteria or not. Because there are some criteria which are beyond these, but they have not shown to be very much useful. And at least Milan and Edusurg have given fairly good amount of survival advantage and disease-free survival as well. So the either the tumor is unifocal or multifocal, that is a very important thing, because that will change the prognostication and even type of management we are looking. Whether the location of the tumor which is located is it resectable or it is easy to resect. Like if there's some tumor sitting in the caudate area which is involving the vessels, it becomes very difficult for us to resect, right? So associated conditions like whether the patient is having portal hypertension, although liver function is preserved, but if there is significant portal hypertension, which can be diagnosed by either looking for platelet counts or HUPG or the presence of varices and all. So this also can be a deciding criteria for these patients. So the main concern which we normally face in early tumors is that if the disease is multifocal, then that becomes a slightly problematic thing in treating these patients, because a few studies have shown that at the primary diagnosis, tumors in approximately 35 to 40% patient can have multifocality. So there are few studies going on these patients, whether when the tumor is multifocal, we are not sure whether there's an intrahepatic metastasis from the larger tumor to a smaller area, or like a field effect, it is originating from all the areas. So both things are concerning. If it's a metastatic, then we don't know whether the tumor has metastated outside or not. So, and if it is multifocal, then whatever is the parenchyma remaining back, will that be good enough to sustain for a long time, or it will form tumors again? So normally, as of now, the literature which gives us that resection for multifocal tumors has not shown any much good survival advantage. This is why I should have hardly 0 to 95% survival in these patients. Although the paper was published quite long in 2008, there might be some better papers from this, but maybe I couldn't go through it. Secondly, the Barcelona staging, they also recommend resection for solitary tumors. If there are multifocal tumors, then again, it goes out of the resection margin. And the EASL guidelines have shown that there are poor outcomes when we operate or do resection for multifocal disease. So what are our worries? Because the SCC, which are occurring in the background of cirrhosis, it's a fertile ground for them to form tumorigenesis. And such background vegetative nodules, or they can also have some microbe tumorigenesis going on as a field effect, and they can form tumors again. So these patients, liver function is fair. Yes, we have all the options. Again, portal hypertension assessment becomes slightly cumbersome, because usually we avoid the invasive methods to diagnose this thing, and we rely solely on the endoscopic findings of varices or maybe a platelet function or presence or absence of ascites. So as Gunjan has already said that meburofen can come up to find out what amount of liver function is remaining, and whatever liver function is remained is adequate for the patient or not. So that can help us to find out whether the remaining liver will be helpful or not. And again, the etiology of cirrhosis is important because there are few etiologies like where there is a active chronic hepatitis going on, more commonly in hepatitis B or hepatitis C, which are which have more risk of getting tumor recurrence and forming multifocality of the tumors. Again, same type of aggressiveness of the tumor can be assessed by having AFE levels which are usually more than 100, right? So these are the problems which normally makes us think whether we should go for resection or we want to replace the complete parenchyma so that these factors can be removed from action. So as we said, there are two options. Either we can go for resection, try to do a single anatomical resection, or do for a multifocal tumor, do a non-anatomical with anatomical resections, or have options of LDLT or DDLT. DDLT here will not discuss much because we know that there is a waiting list at least for 6 months, even in very well-known areas where DDLTs are common. So more of LDLTs are commonly being done for these patients who have liver dysfunction as well as cirrhosis, hepatocellular carcinomas. So how to use the ideal treatment? So we should see that this treatment should be available for the patient. It should be feasible. Then the treatment should give a good amount of effectiveness in the form of reduced recurrence rates, good amount of recurrence-free survival, and they should add up in the overall survival as well. And cost should be in the limit for the patient so that which can be affordable. So there are the general guidelines where we can choose the ideal treatment for these patients. So do we think that the transplant results are promising for these patients? So as per the studies, so this was one of the meta-analysis shown by Penario et al. So what they showed multiple types of criteria like Tokyo criteria, Kyoto criteria, Azan criteria. So if you see the criteria, none of the criteria are lesser than Milan criteria, and most of them are more than the UCSF criteria. So despite having aggressive tumors, the 5-year survival rate has always been more than 75%, and sometimes it has gone to overall survival, and the disease survival has gone more than 90%. That is commanding. That at 5 years, if you are getting tumor-free survival of more than 90%, 95%, that is very good. You should expect all these results. So when we go for when we see these same things in the resection part, we always see the results are hovering between 50 to 40%. So here there is a huge amount of gap between the disease-free survival and low recurrence rates. So I think here the transplant has some amount of edge. So if you see, this is the same study where they have seen the 5-year survival, 5-year recurrence-free survival, which was 85 or 84% for the transplant group, whereas it was 44% for the resection group. So either you say cumulative survival, that is overall survival, or recurrence-free survival, both have a good age in transplant. So these two graphs are showing 5-year survival. So here both of them approximately have 80% of survival in the recurrence-free part and OS as well, whereas resection has definitely lower. So what resection has to offer, Prasad has already cleared. So I don't think I should explain all this thing that what is the rates of recurrence and survival in these patients. But my worry is what if the recurrences occur? So how will you manage them? And when they come up, will they in a condition that we can do a recurrence, we can give them R0 resection again or a transplantation? Yes, salvage transplantation is definitely a role there. But we need to know how many patients we can offer a salvage transplantation. So if the numbers are not big, then we have to think twice before offering them a resection. So this was a study by Sindhu et al., where they have studied solitary resection of a tumor which was less than 5 centimeters. So when they analyzed the resection, they found out that the recurrence rate was approximately 50% in anatomical resections and 67% in non-anatomical resections. And definitely those patients who had underlying cirrhosis, presence of microvascular invasion and micrometastasis. So these were the tumors who were definitely had a increased risk of resection. So here when you are talking about childhood cirrhosis, all of our patients are cirrhotic. So definitely all of our patients are at high risk of recurrences. So this makes us know, okay, if the recurrence comes in the liver itself, will change the liver. Then we need to know how many patients are having the recurrence in the liver itself. Because the only way when you can do a salvage transplantation is that when there is solely intrahepatic recurrence. So in a study by Cha et al. In 2003, they had studied approximately some 500 patients over a period of 10 years and found it out that the recurrence rate was approximately 55%, where 90 patients had recurrence. And obviously they were treated by multiple means, of which 14 only were resected. So when we see this recurrence, although most patients have a solitary intrahepatic recurrence, but if you see almost 5%, I mean 10 to 15% patients usually get either oligonodular recurrence, or they are multinodular, or there are extrahepatic recurrence. So approximately 80 to 85% patient can be only considered for the transplantation in a salvage way. And again, when Dr. Poon et al., when they studied these recurrences, the presence of cirrhosis itself was a very big factor, which was showing high recurrence rates. And even more than one tumor is also associated with high tumor recurrences. So this becomes slightly cumbersome for us to give them a direct resection as a rule, because we know within 5 years they'll come back with a recurrence, and then we will not be in a condition to offer transplant for each and every patient who was transplantable before. Right. So when we see the multifocality for these patients, those patients who are multifocal had a definitely poor outcomes in the form of BCLC survival. So in 5 years of duration, almost every patient of this study had a recurrence. So multifocal disease will definitely have an edge or a resection when we transplant them, and they will have a definite a good amount of long-term resection disease-free survival as well as overall survival. And this was studied by Zhengzhou et al. In 2020, where they studied specifically child A cirrhosis patients who had a early HCC, and they did a prospective study wherein they compared resection versus living donor liver transplantation. So in this, there was a subgroup analysis done where the multifocal disease were separately found out whether the multifoci were lying in the same lobe or they were in different lobe. So when transplantation was done, there was no significant difference between the survival and recurrence-free survival of these patients when the hepatic nodules were in different lobes. But when they considered the same thing, the resection part, when the resection was done for patients where the disease was in multiple lobes, they had definitely very poor recurrence-free survivals. So almost 90% patient developed recurrence within 72 months. So here we can understand that the recurrence, the outcomes of a multifocal HCC are definitely much better in patients with liver transplantation. So what to choose then? We should go for resection or liver transplantation. So this was again a recent study in 2019, which was published in Transplantation Proceedings. They had seen child A patients and divided into two groups for transplant as well as resection. The data of the preoperative data was almost matching, although there was some increased rates of multifocality in transplantation group. So when we saw, as Prasad said, that there is some increased complication in transplantation, but I could find some reverse findings here. Although the difference was not significant, but there were no much more complication in these patients. It's 28% transplantation, 13% in post-mortem complications. But here the difference was not statistically significant. But if you see, the overall mortality and hepatic recurrence rates were significantly higher in patients with resection. And again, this is the survival function where it shows a cumulative survival, which was definitely much better in case of transplantation patient than the resection. And again, this was a meta-analysis published in American Transplant Congress, which also showed that the 1 year and 3 years and 5 years survival and disease-free survival was significantly higher in patients with liver transplant and recipient than the liver resection patients. So the data will always be contrasting, and it's very difficult for you to pass a blanket statement that only one modality is better. Similarly, Rene et al. Was a guy who was initially started these studies. Although this paper is not showing specifically child A patients, but here we see that the first group is for resection, second group is for transplantation. So first group showed definitely a relatively preserved patient, second group is sicker patients. and the resection group had a usually low patient, less patient with multifocal disease. Transplantation group was increased patients with multifocal disease. So overall, bad disease and bad function was present in transplantation group. So still, the recurrence rate was much higher in case of liver resection. So although the liver function was bad in transplant, the tumor number and the size was bad in transplant, the recurrence rates were still higher in resection. So that needs to take a point. Here the recurrences, almost we can say 7% in transplant and 11% in resection, they were extrahepatic. So they again go out of your salvage transplantation list. And the disease-free survival, that is alive without disease, were significantly higher in liver transplant group than the resection group. So this is the same graph from the Zhang Zui paper, which shows definitely advantage in overall as well as recurrence-free survival in patient with transplantation as compared to the resection group. So again, I'll come back to the same slide which we discussed. Then how to choose ideal treatment. So if you see transplantation 10 years back, it was a very difficult access. It was not available at multiple centers, but now availability has been there. It is feasible. There are so many centers are doing the surgery, and the results are almost matching the global standards. Effectiveness, we just discussed that definitely transplantation gives a long-term recurrence-free survival and long-term oral survival as well. The recurrence rates are definitely lower with transplant, and oral survival is definitely up. So cost is the issue which I think comes in the end, because although the cost of resection somewhere is 1/3 of the transplant or maybe 1/4 of the transplant, but when the things come for survival, sometimes costs you have to keep at backseat. So a take-home message, what I could derive from that, since we already said it is never a black and white that transplant yes, liver resection no, I will not be saying that. But liver resection has a definite role in a carefully selected patient. So don't label that this child A, so just go for resection. So very early solid tumors with background compensated disease, when there is no itis going on, so there is no hepatitis, the FA levels are very low, these can be carefully selected and giving them an option of transplant as well. And you can leave that decision to the patients. The liver transplantation definitely provides an upper edge in early HCC, when even if the disease is multifocal, in terms of low recurrence rates and long survival times, especially in those patients who has a high grade of hepatitis B ongoing disease or hepatitis C, or there is some amount of liver dysfunction which is being picked up in a high HUPG gradient, and obviously for the multifocal disease. So I'll conclude by saying that a careful patient selection and individual surgical plan needs to be given for all patients, and that only can be used to upgrade and get best outcomes from our surgical treatment. Thank you so much.